with endocrine, I'm not going to spend a lot of time with hypoglycemia. I'm going to quickly review hyperglycemia issues. Bottom line, with diabetes, y'all know what diabetes is.
The sugars.
The sugars. The big thing to know is just the difference in the type 1 and type 2. Type 1, that's usually genetic. No insulin production. You've got to have insulin. Type 2.
How early can you tell that? Or like, how early does that normally occur?
You know, I think really at just about any childhood age. I'm not exactly.
Yeah, the normal,
sure.
the average is 8 to
I was
11.
waiting on Sarah Catherine to pipe in. So
The average is 8 to 11, but I wasn't diagnosed until I was 18. And like, they're straying away from juvenile diabetes and just calling it insulin dependent because more and more people are being diagnosed older.
Yeah, and the thing is that, you know, you've got type 2, which was formerly adult onset. I keep saying I'm going to fix that, and I'm going to fix it right now. But what we're actually seeing is that patients that are not able to get their type 2 diabetes under control become type 1 diabetics, because the pancreas can only take so much shock to it. The pancreas can only take so much work to it, right?
Yeah, my mother just recently went back to the doctor after 11 years, and her A1C was like 16 point something.
What?
Yeah, well, I mean, okay, so the thing is that at the time her endocrinologist said that if she could get below a certain weight, then she wouldn't have to take anything for diabetes. Now, keep in mind that this time she was on a pump. It's been a roller coaster ride. So it started out gestational because, well, you've seen me, I'm huge, so I messed her pancreas up. But anyway, so she's been.
You messed her pancreas up?
Yeah, I was a fat baby. So, she's back on like metformin. So now her A1C was, I forget what it was, but yesterday her sugar was like 147 and everything. So I mean, like, she's doing like way better. But you know, for those 11 years having had nothing, you know, I was like, your sugar has probably been this high for a long time, like many years. So
yeah, she probably feels better than she has felt in years.
Yeah, she did. Well, not at first. She said she felt terrible at first. Like right at the beginning.
Yeah, at first it's the worst feeling in the world.
but now that, you know, it's like controlled and everything, she had to go like on a plant-based diet and everything else. But yeah, she's feeling a ton.
Did you say she was on a pump years ago, an insulin pump?
Yeah. And the doctor she's like, I don't know why you were ever on an insulin pump. You were never a type 1 diabetic. I don't know why she's not using the same endocrinologist now as she was. But I mean, it was a really messed up whole situation.
So when she was on the pump, did she have issues with hypoglycemia a lot and all that, or?
Not that I can recall. I mean, like I said, I was younger, so
yeah. I
mean, she got off of everything when I was like in 8th grade, 9th grade, something like that. So
right.
I mean, before that, I didn't really understand a whole lot about what was going on. I just knew that, you know, her sugar was high, and then that kept it lower. So
that's an interesting story. You don't usually hear somebody being on a pump or insulin and then going to being treated as a type 2. You usually hear it the opposite way.
Right. So
interesting. So with your type 2, kind of in the same conversation that Sarah Catherine was saying, you know, you don't say type 1 is juvenile. They've gotten away from that. Type 2, they've gotten away from adult onset, instead calling it non-insulin dependent. Anybody want to take a gander why?
Big old kids.
Fat kids.
I was being a little more politically.
But I don't mean like big boned like Dom was. I mean like, you know, the kids, right. Like you seen the commercial of the little kid that's playing video games and he calls his grandma on the telephone and she gets up from the chair and goes and it's like, hey grandma, give me another grape soda. Like, you can get your butt outside and walk. But honestly, like, I guess that's one of the things that I don't have a filter on is that when I start talking about fat kids. But I mean, seriously, like, it really is sad when you're seeing the state of kids that they're in now. And so they can't call it adult onset because you are seeing adolescent onset diabetes. And
thank you, McDonald's.
Yeah. And I can't sit here and say, you know, anything, because my wife was getting on to me yesterday about my healthy habits with eating cookies and stuff like that, you know. But
you becoming
I'm not a fat kid. And then gestational diabetes is you know, usually or usually limited to just during the pregnancy or shortly thereafter. And that's really just a whole different beast, and that's essentially because you've got a parasite in your stomach that's feeding off of your sugar reserves. And so my wife heard me and she agreed. You know, and of course your treatment with diabetes, I mean, it's going to be, you know, if it's hypoglycemia, then you give glucose, you know, one way or another. We are hyperglycemic disorders. So with those, there is...
What about gestational hypoglycemia?
Gestational hypoglycemia?
Yeah, like when Catherine was pregnant, we didn't find out like that she was hypoglycemic until she had a seizure. And yeah, so she was like, you know, walking and talking, and her sugar was like 40, and the doctor was like, "You're just gonna have to eat constantly, like, you know, snack constantly." And I thought that was strange. I'd never heard of it, but yeah, her sugar ran extremely low during the pregnancy.
Yeah, and if it's a situation, you know, most likely if you're on the ambulance and you get called for that situation, you're going to be called for a seizure, right? And, you know, it's like we were just talking about just a minute ago. Our main thing there is going to be, you know, initially is to check a glucose level, and you know, if they're pregnant, you're going to give glucose. I mean, it's just a simple carb that's what they need. That's interesting. Now, the scary thing about, you know, the seizures in pregnancy, though, because if I get called to a pregnant patient that for seizures, like, my mind's not even going to hypoglycemia calls, you know. My mind's going to eclampsia. So I'm checking blood pressure. I'm checking, and I am checking glucose, you know, and all that. But, you know, that's one of those situations where you definitely would need to be checked out, like, if that happened. But
she said her A1C was 3.7.
Oh, wow.
Yeah.
Wow.
So what would happen if you have a preeclamptic pregnancy and you get hypoglycemic, have a seizure, and we give MAG?
Probably, it probably would cause some issue, to be honest.
It would throw it into dysrhythmia, right?
Yeah, I mean, not only that, but it may even cause, you know, issues with contractions and all of that as well. I would probably think that you would need to check blood pressure, check blood sugar and all that, and then get on the phone with a doctor and that, because usually if folks are eclamptic, they've had a history of preeclampsia, you know, which is, I guess that's what you just asked, is if they were preeclamptic and then that. But yeah, I mean, that's very much within the realm of possibility, you know. But you know, I don't know.
Would you correct the sugar before you give a MAG?
Yeah, definitely. And if I remember correctly, I think that MAG is a category B. So you would definitely want to be on the phone with the doc. All right. Your hyperglycemic disorders, I'm going to move to the next slide. I'm going to hit on these other thyroid disorders, but I'm going to move to the next. Oh, I thought I had it. Never mind. I thought I had a chart in here. Your hyperglycemic disorders, remember DKA, diabetic ketoacidosis, is typically the hyperglycemic disorder of type 1 diabetes. because you have the ketones that are created because there's no insulin being created at all, and so there's no glucose getting into the cell, and so therefore we're having to go to essentially self-cannibalism and go from there. Have I've told y'all my little anecdote to how DKA works, haven't I? About us all being trapped in the classroom.
Yes.
Okay, well, I'm not going to go into that again. Your hyperglycemic, hyperosmolar, non-ketotic coma, I've never seen a disease like this with so many different names, because you may see it as HNK, hyperglycemic non-ketotic. You may see it as HHS, hyperglycemic hyperosmolar syndrome. You may see it several different things, but basically diabetic ketoacidosis and HHS, the field treatment is going to be the same. With DKA, you may see the Kussmaul's breathings, textbook-wise. You may have the acetone, fruity smell on the breath. I've not really experienced that. I usually feel like I can do a good enough assessment by doing blood sugar and seeing Kussmaul's respirations and all that to determine that their blood sugar is high without having to sniff their breath. That's because they're acidotic and they have the ketones. They are not typically acidotic per se with your hyperglycemic hyperosmolar non-ketotic coma. If they become acidotic in this situation, it's because there's not as much insulin to move glucose and potassium, and so the potassium starts building up in the system, and so there's a direct link with buildup of potassium and the hydrogen ion, and so they may become acidotic that way, but it's not because of the byproduct of the ketone production. Bottom line is that it causes osmolar diuresis or hyperosmolar diuresis. Essentially, it means that the blood is full of large glucose molecules that when they get to the loop of Henle and within the kidneys, the nephrons in that area, what happens? The kidney does its job, right, by trying to pull the waste and the solutes off, but what does water do with large molecules? Follows them, right? And so the water is going to be pulled out with the glucose, and along with that, you're also going to have some other electrolyte issues as well, right? And in this case, you actually see more sodium being pulled out than you do potassium. Potassium kind of retains in the blood, and so they're just pouring urine out. And so what happens in that case? Well, the body is registering, hey, we are fluid depleted, so they become very thirsty, right? And then the body's also saying, hey, we're starving, because you do have cellular starvation. In HHS or HHNK, there is just enough glucose that is allowing a small door to open and throw a little bit of glucose into the cell to not have to resort to eating itself. But it's not enough to pull more glucose in, or there's just enough insulin if I say glucose, but there's not enough insulin to pull more glucose in, and there's not enough insulin to really help pull that potassium in as well. All right, remember, potassium is supposed to hang out intracellularly, right? But the potassium actually gets pulled out of the cell in response to what's going on the outside of the cell. So in this case, you've got all these large glucose molecules, and we're just dumping it out. The brain is reading, hey, the cells are starving, so they are very hungry, they're very thirsty, and they pee a lot. I have seen countless people come to the ER for just general malaise, just general not feeling well, leave a few days later after being put on an insulin pump in the ICU and having to be educated as type 2 diabetics now. Because folks may go months or years as a type 2 diabetic with just sludge in their veins because of all the glucose and just absolutely feel like teetotal crap. And that's usually why they go into the hospital. Okay? So, everybody got a good understanding of DKA and HH&K and all that? All right. Let's take about 3 minutes so Eric can get up and walk around, get a little blood flowing. Oh, it looked like you fell asleep on me.
Me?
Yeah.
No, I did be drooling and snoring.
Oh, okay. Well, do y'all need a break, or are y'all good?
I'm fine.
I don't know if Walker and Andrew is with us. Travis?
I'm here.
Oh, okay. I hear y'all every now and then.
Yeah, I'm here.
Okay.
Yeah, I'm here.
Cool. Okay. If anything in this lecture today, a couple of things that I really want you to kind of take with you is what we're going to talk about now with these disorders of your thyroid and adrenal, because they can have some disastrous effects on the body, but they're not seen that often. And if they are seen, oftentimes they're overlooked. Somebody that has a disorder with a thyroid gland, whether it is hyper or hypothyroidism, and so let me put it in reverse, Terry, just a minute, and just mention something about endocrine disorders. Endocrine disorders, and your book says this, but endocrine disorders, they're going to be caused by either an overproduction of a hormone, an underproduction of a hormone, or I don't want to say incompatible, but a bad interaction of that hormone and its target tissue. But most of the time, you see these disorders because of the overproduction or underproduction of the hormone. Remember, the body likes its numbers. The body likes its normal processes. We are creatures of habit. And not only do we like it, it is absolutely necessary to maintain life and to maintain homeostasis. And so when you start seeing, think of, in a sense, and just momentarily, think of hormones almost as these chemicals or these drugs that have a very, you remember the term therapeutic index when it comes to drugs, right? Either too much of the dose, it becomes very toxic for the patient, or too less of a dose, it can either not have an effect or it can actually cause other effects. And that's kind of where we're at with the endocrine system. You know, the endocrine system across the board kind of works on that negative feedback, meaning that it takes a change in the body in order for that signal to be produced. It's not a proactive, it's a retroactive system. Does that make sense? Just like if you're sitting in your house, you get hot, what are you going to go do? Unless your dad is you know, like got a belt and says, I pay the bills and you don't touch my air conditioner. I'm not that dad. I would rather pay for AC when it's 100 degrees outside. If you're hot, bump it down, baby. Okay. Baby, I'm teaching right now. Let's take a quick 2-minute break. There's a scary bug in my daughter's room that I've got to go take care of. I'll be right back, okay?
Don't get bit.
Buddha. Does anybody know if Mafias is seeding?
All right, y'all, I'm very, very sorry about that. It was a dead, crusty cockroach that had already gotten ate up by the poison that she freaked out over. So anyways, Dad to save the day. Okay, so anyways, you know, the negative feedback. Y'all got that. All right, so thyroid disorders. Hyperthyroidism. So thyroid hormone, too much of thyroid hormone, or T3, T4, will actually cause issues that almost mimic a hyperactive sympathetic nervous system. So somebody that has not necessarily the emergent disorder, all right, so thyroid storm, thyrotoxicosis, myxedema, these are going to be the emergent disorders of these two things, but somebody that is just chronically has hyperthyroidism, they have an overactive thyroid that produces too much thyroid hormone. They're going to be very skinny. They're going to have a heat intolerance. Y'all remember this? Heat intolerance, very skinny, because thyroid hormone actually increases metabolism, causes an increase in metabolism, and so that's very important when it comes to the actual emergent aspect of this. You know, typically they're going to be just very, very jittery and, you know, things like that.
You said this is hyper?
Hyper, yeah. Whereas somebody suffering the effects of hypothyroidism, they're going to have a cold intolerance. They're going to have a decreased metabolism, meaning they're going to gain more weight. They're going to be more swollen.
That's my problem. Got it.
Yeah. Yeah, that's it. That's absolutely it.
It's not the 15,000 calories a day. It's just my thyroid.
Yep. Yep. Dom, you're something, man.
I've always thought you were special too. Thanks.
I know it. I had a little tingle in my heart when you actually checked on me yesterday. I don't think I've ever had a student check on me. Thank you.
Oh, well, you're welcome.
And for that, I'm grateful. And I think it was really just you trying to keep me from being mad because you were an hour late to class. But nonetheless, I forgave you. A couple of the actual disorders of Graves' disease. So Graves' disease is going to be a hyperthyroid issue where you actually is autoimmune, and there's antibodies that are generated that stimulate thyroid tissue. So these antibodies actually, the autoimmune system creates these antibodies to work against the thyroid system, and so you have hyperthyroidism. 6 times more common in men than women. Again, cardiac dysrhythmias you may see. So if you can think of essentially what you would expect if somebody had a sympathetic response, like constantly sympathetic nervous system, like think adrenaline, epinephrine, norepinephrine, except these signs and symptoms are not caused by the norepinephrine and the epinephrine, they're caused by the excessive thyroid hormone. Agitation, mood changes, poor heat tolerance, weight loss despite increased appetite. Typically with these patients, cardiac dysfunction is going to be a huge issue. Sometimes these patients are actually put on adrenergic blockers. So not beta blockers, but alpha blockers. Well, maybe beta blockers, and then glucocorticoids sometimes. Now, if somebody has hyperthyroidism to the point to where it has completely affected their body, oftentimes they may actually have to get iodine treatments that in essence kills their thyroid gland. They may have to physically have their thyroid gland taken out of commission. Another sign with this is the exothalamus. Remember that? Exothalamus. I guess I may walk her mad. He left after I called him out.
Oh, sorry, I forgot to tell you. He texted, said his internet went out.
Oh, okay. I didn't know if he needed to go get somebody to put gas in his car or something.
Yeah, you probably upset his internet.
Probably did. Y'all remember exothalamus, the eyes bulging out, a very characteristic sign of hyperthyroidism. Where we worry about, though, is thyrotoxicosis or thyroid storm. It's very hard to diagnose in the field. And a lot of times it may even go undiagnosed in the hospital for a time because just it has like just this well, number one, is kind of poorly understood on exactly what the mechanisms are, what gives, why do we go from just Graves' disease or hyperthyroidism into this actual where we're just getting bombarded by thyroid hormone in the body. But essentially, you'll see just this hypermetabolic state. It can be deadly. I mean, and that's why I mentioned that with the thyroid stuff earlier, because if you can think of a situation, in this situation, you know, typically when we get into a sympathetic response, yes, it is going to require more, you know, of our reserves, but we usually come back down off of that and our metabolism will slow back down. You know, we get out of the fight or flight. But in this situation, it doesn't. So what happens? You got a hypermetabolic state. You have high fever. It affects, and the fever is not caused because of inflammatory response. It's caused by neuro effects. Irritability, tachycardia. So essentially, you may find this patient that's got a heart rate of 180, may have a blood pressure of just really high, and they may be in a coma. They may be burning up to the touch where it almost maybe even may mimic a infection, except they're not showing other signs of sepsis. You may even see other things like hypotension with it. The bottom line here is that you need to try to get a history. Do they have a history of thyroid issues? Most of the time, patients with Graves' disease are going to be on treatment to prevent this from happening. And essentially, what's happening here is that you've just got a ton of thyroid hormone that's just being dumped into the blood, and it's shifting around, and it's hitting all these cells that are not the target cells. Nonetheless, if you find somebody like this, symptomatic management, supportive care, fluid resuscitation, monitor, be prepared for cardiac arrest, because that could happen. Okay. Hypothyroidism, on the other hand, you're going to see the exact opposite. Low metabolic function, maybe even early signs of poor organ function. If somebody is hypothyroidism, they have to take synthetic thyroid or Synthroid. Oh, it's my wife's watch. This working from home does not work out good for me. And I apologize for all of the distractions. But with these patients, cold intolerance, fatigue. Hello, Leanne. Hey.
Listen, the other day, what day was that?
Hey, I'm still in class teaching right now. Is it, can I call you back?
Well, I'm going to text you Danny's phone number. I asked real quick, I asked the owner about Lake Martin ZR the other day, and he is a go for it, but Danny needs to talk to you, so when you get a minute, after class, can you call him?
Yeah.
I'll text you his phone number.
Okay, I sure will.
Okay, thank you.
All right, bye. That was one of your classmates. How about that? Okay. Well, if Leanne goes back and watches the recording now, she will see her cameo appearance.
She came up here to the fire department. Had to get some copies, man.
Oh, okay. Just know this, that somebody with hypothyroidism, this may result, or this may turn into myxedema. Myxedema coma is a hypothyroidism emergency, all right? And with this case, you may have somebody with decreased mental function. They may have a history of hypothyroidism, and it may just be a situation where, you know, hey, there's something going on with this patient, and we just can't get to the bottom of it. All right? Adrenal disorders, where your adrenal glands sitting on top of your kidneys, right? Your little triangle-shaped glands that can cause some big issues. Now, one of the things about the adrenal glands is that they produce very important hormones, glucocorticoids, mineralocorticoids, androgens, and also cortisol. Addison's disease and Cushing's syndrome both affect the adrenal glands. Addison's disease, characterized by progressive weakness, fatigue, decreased appetite, and weight loss. Cushing's disease actually can occur when somebody is on chronic steroids and then they stop taking them, and it affects the cortisol production. There's another another name for cortisol. It's called the stress hormone. So cortisol is produced when we're under stress. With the effects of cortisol production with like Cushing's syndrome or something like that, you may see that patient having, you know, weakness, fatigue. But with Cushing's, textbook characteristics of Cushing's is going to be the moon face, the buffalo hump on their back, right? Thin skin, things like that. All right. Usually they're very easy to tell that they're experiencing that kind of stuff. Okay. Just as a really quick reminder, I just want to make sure you guys remember that there are different types of insulins for somebody with type 1 diabetes. You've got your long-acting. You've got what's called your basal dosages of insulin, which is it may be the Humulin or the insulin glargine, the Lantus. These are going to be, if you notice here on this little table here, you see onset, peak, and duration. If you notice here that the long-acting has a very long peak with a very long duration, and the insulin glargine actually has no peak, just meaning that it's what we call a basal dosage of insulin, where it kind of helps maintain the function, but it's not going to target high carb loads. So the insulin glargine or their long-acting insulin, they're going to take their basal dosage of insulin every day. All right. One of the big things that affects people with type 1 diabetes is going to be sick days where they've got infection, or strenuous exercise, unplanned activity, and also diet issues as well. But somebody may not, if they're sick, they may not need to take what, you know, their rapid acting or their bolus dosage. So you got basal and bolus dosage. So your bolus dosage of insulin, that's going to be sometimes what's on a sliding scale, or if you've got a pump, you've got kind of a sliding scale where you determine how many carbohydrates, not necessarily just the sugar content, but the carbohydrates that are going to be in the food that they eat, and then they base their dosage of the regular acting insulin off of what they're about to eat, so almost like meal coverage. All right, but the long acting, they have to take that, they're supposed to take that every single day. They may not, if they're sick, they may not, you know, it's never advised for a diabetic not to eat, but you know, in some situations they may not be able to or whatever, and they may not take their regular insulin. And then sometimes and it's not always the case, but sometimes the case of you know, dealing with somebody, taking care of somebody that's hypoglycemic, is that they might have taken their rapid acting or their meal coverage, or they may even have taken their long acting and they just have not eaten, or somehow their diet got off. Anyways, there are differences there. For type 2 diabetes, so type 2 diabetes is going to be typically, now this is actually coming straight from your standards, and so they did feel like you needed to at least kind of have a general knowledge of the types of medications. I'm not asking you to memorize these medications by any means, but just kind of understanding that there are oral agents, and there's even injected agents of medication for type 2 diabetes, but they act differently than the insulin. As you can see here, there's 4 classes listed here, and they either affect the synthesis of the glucose, or they affect this the insulin secretion of from the pancreas, things like that. So 2 of your common ones here, your sulfonylureas. All right, these actually increase insulin from the pancreas, so they help to increase the movement of insulin from the pancreas. Glipizide and glyburide, those are 2 of your common ones that you'll see. Metformin, you know, Dom even mentioned metformin just a minute ago. Metformin is probably one of your most common and one of your oldest type 2 diabetes medications. Decreases glucose synthesis and increases glucose uptake. So it actually helps the insulin work a little better. All right. With metformin, one of the things about metformin is that a patient on metformin, they have to actually not take that medication if they know that they're going to have a heart cath or have dye, like contrast. There's a certain amount of time they have to be off of this glucophage in order for them to be able to actually have the heart cath or whatever, because it interacts with the dye. You've got alpha glucosidase inhibitors, delays carbohydrate metabolism, which moderates the increase in blood. So it helps the body not metabolize the carbs as quick, so that you don't have a rush of the carbs. And you know, the whole process here with the way that we eat is the fact that we have catabolism of the carbohydrates, right? We break down you know, the simple carbs that we eat into complex carbs, and then you've got I'm not even going to try the T word there, where it promotes tissue response to insulin, which makes the available insulin more effective. So again, these different types of drugs, these oral agents, they're not insulin per se at all. They are drugs to help the body either synthesize the glucose differently, break down the carbs, or make the insulin work more effectively. Now this is old, so there's been more classes of drugs like this come out, but these are the common ones. All right, and then you know all of your hyperglycemic agents there. All right. Any questions there?